Hey everybody, and welcome to your Heart 2 lecture. I'm going to display your case study for this lecture on the screen in just a second. If you were assigned this lecture to watch on your own, please enter the answer or your diagnosis in Canvas on the day that it's due, or by the day that it's due. If you watch this lecture in person and you're watching this for review, then you probably already submitted your case study. But here's the case study, and then we'll get started with the lecture. So I'll keep this up for a couple seconds, or you can just pause the video, and we'll get right into Heart 2. Okay, so just a bit of a review. You should have completed your PLA number 4, I believe, which is trace a drop or trace a red blood cell through the heart. And so the blood flow should be superior and inferior vena cava. I believe for your PLA, it started off at the inferior vena cava. Typically, hold on. Okay, typically, on an exam, if I ask you to trace a drop or do a pathway, you're going to choose just one pathway. So choose either superior or inferior vena cava. But I'm going to show you all possible pathways here. So superior and inferior vena cava, or vena cava, if you're talking about plural, are going to drain blood into the right atrium. And then from there, the blood is going to flow past the tricuspid valve into the right ventricle, and then past the pulmonary semilunar valve, up through the pulmonary trunk, out both of the left and right pulmonary arteries. Again, if this was during an exam, you would pick one of the pathways, either left or right, and keep going. Then to the lungs, where it will approach some capillaries so that we can have some gas exchange. We're going to pick up some oxygen, and then we're going to drop off some CO2. So the blood that exits the lungs is now oxygenated. We started off in the superior and inferior vena cava with deoxygenated blood because we just delivered all of that tissue, or all that oxygen to the tissues. And so it's all deoxygenated blood until it approaches the lungs. We have gas exchange and we pick up oxygen. And now the blood that's coming back to the heart is now oxygenated. And it's going to go through the pulmonary veins, left and right, to enter the left atrium, past the bicuspid valve. Remember, you try before you buy. And you can also call it the mitral valve, whatever your preference, down to the left ventricle. And the left ventricle is going to pump that blood past the aortic semilunar valve, through the aorta, and then to the body. Okay, which means all of the organs, we're going to supply all of the organs with oxygenated blood so that we can give them oxygen. And that's it. Okay. So I guess we can go through it one more time without the explanations in the middle. But again, superior and inferior vena cava, to the right atrium, past the tricuspid valve, to the right ventricle, past the pulmonary semilunar valve, to the pulmonary trunk, to the left and right pulmonary arteries, through the lungs, back to the heart, to the left and right pulmonary veins, to the left atrium, past the bicuspid valve, to the left ventricle, past the aortic semilunar valve, to the aorta, and then deliver all that oxygenated blood to the body. Okay, that's it. So first we're going to focus on the anatomical differences between the different muscle types, more specifically between skeletal and cardiac. You should already know the structure and function of smooth muscle. You should actually know it for all of them, but we're really going to make the differences, or show the differences between skeletal and cardiac. Okay, so the key concept though at the top of the screen is that intercalated discs connect cardiac muscle fibers into a functional syncytium. And what that means is just one big functional unit. So the heart contracts all together, and it is the gap junctions that allows it to do so. So if you see here are the intercalated discs that you should have learned in Bio 32. Looking at different tissues, looking at the cardiac muscle tissue, you should have seen intercalated discs. That is a unique structural characteristic of cardiac muscle. No other tissue is going to have these intercalated discs. Okay, they are unique to the cardiac muscle. The intercalated discs have the gap junctions which are pores in the plasma membrane between two cells, so that the ions can travel across, and so the heart can contract in unison, or the cells of the heart can contract in unison. And also, in those intercalated discs, you're going to find desmosomes. So desmosomes are the junctions that contain anchoring proteins on the inside of each cell, so that when the heart does contract and those cells kind of pull apart from each other as they're shortening and lengthening, those cells don't rip apart. So it anchors them together. So even though the shape is changing of those cells because they are contracting, they're not going to pull apart from each other. Okay. One thing though about cardiac versus skeletal, if you look back at the previous slide, you can see that both the skeletal over here and the cardiac over here are striated. So know that both types are striated, and this should be a review. Both types are striated. However, there are some unique characteristics for cardiac muscle tissue. So the intercalated discs, yes, but also branching. So you'll notice that with skeletal muscle, I'm going to bring out a little pin. Skeletal muscle, they are cylinders, straight cylinders, okay, of cells here. Okay, the cells are cylinders, so they're all running parallel to each other. They're all straight lines here. Okay, each cell is a cylinder, a long fiber, muscle fibers. So they're long and they are parallel to each other. For skeletal or cardiac muscle, however, you'll notice that you have some branching occur. The organization is not as neat, I guess, as the skeletal muscle. So you'll notice here's a cell that branches off. Here's another branch over here, okay, going in this direction here as well. So there are branches of these cardiac muscle cells. So they're not in straight lines right on top of each other. These cells are going to branch off in different directions. And smooth muscle, which again, we're not going to focus too much on today, no striations. They are spindle shaped, if you remember from Bio 32, meaning that they're fatter in the middle than they are at the ends. But that's smooth muscle. Okay, so if you remember, the sarcomere is the smallest functional unit of muscle. So if you need to go back and review the sarcomere, so remember you have an I band, which contains thin filaments only, which is your actin. You have the A band that contains both thick and thin filaments, so your actin and your myosin. The H zone is the middle that has the thick myosin proteins only. However, that H zone, also known as the Baer zone, I think it was called the Baer zone in your Bio 32 lecture notes, that will actually disappear when the sarcomere contracts and those Z discs get closer to each other, and that H zone will disappear. Okay, because this is a relaxed sarcomere here, but when the sarcomere contracts, these are going to move towards the middle, and you're not going to have that H zone or that Baer zone anymore. Okay. Okay, so sorry, I had to figure out where I out of my notes. But for skeletal muscle works through what are called motor units. So remember, a motor unit is one motor neuron and all the fibers that it controls or innervates. So here's motor unit number 1 and motor unit number 2. So this motor unit in the purple innervates this skeletal muscle fiber over here and this skeletal muscle fiber over here. Motor unit number 2 is innervating this skeletal muscle fiber here, this one here, and this third one over here. If you don't remember what a motor unit is, go back to your Bio 32 lecture notes or your textbook and review it. But this allows for differences in the amount of contraction coming from a single muscle. So if I were to pick up something pretty light like my glasses, okay, I may be only recruiting a few of the muscle fibers in my hand and my forearm. Okay, but if I were to pick up something heavier, like here we go. This is my little heater that I have next to my desk here. This is much heavier, so I would be recruiting more muscle fibers to be able to pick up a much heavier object. So then maybe not only one motor unit is being recruited, maybe 2 or 3 motor units are being recruited to allow me to have enough force to pick up that heavier object. So with skeletal muscle, you can recruit more muscle fibers if you need to move a heavier load. Okay. I don't know if you remember this before, but the more muscle fibers that a motor unit controls, the more likely it's going to be for bulk movement. So like for your legs or your back, where it needs to be keeping posture and allowing you to take a step forward and things like that. However, for things like your fingers that need to have very precise movements, or your eyes that need to be able to move very quickly and very precisely, those motor units will probably only be controlling a couple of muscle fibers at one time, and that allows it to have really precise movement versus like one motor unit controlling many muscle fibers for just bulk movement, for just standing up or for just walking. Okay, versus like you need very precise and intricate movements for the fingers, for let's say somebody who plays a piano and needs to be able to control very slight movements of the finger, or somebody who maybe knits. Okay, so the more muscle fibers that a single motor unit controls, the less intricate the movement that it's trying to accomplish. But again, if you need to review motor units, go back to the muscular system in your lecture notes or in your textbook. Okay. One other thing that I want to mention, if we go back, when we talked about striations, if I can go back. Remember that these striations are produced by the dark and light bands. So you have these alternating bands. We already looked at it with the sarcomere, but you have alternating bands. Here's the thick in the middle, and then thin on the outside, then thick again in the middle, the next sarcomere, thin on the outside. So these thick, thin, thick, thin, thick, thin arrangements of the muscular proteins, your actin and myosin, okay, myofilaments, that arrangement allows for the dark and light banding that you see with the striation. So the reason why you see this dark light, dark light, dark light, and also on the cardiac muscle, although it's not as obvious, that's because of the arrangement of the actin and myosin. And the lighter bands are the thin bands, and the darker bands are the thick bands, because more light's going to be able to pass through a thinner band, so you get to see a lighter color. Versus a thicker band that won't allow as much light through, so the band looks darker. Okay, so the light bands are the thin bands, which are actin. The dark bands are the thick bands, which are myosin. Okay, so I always think thin actin, tin is thin, actin is thin. I don't know if that makes sense, but actin is the thin one, and then myosin is going to be the thick or dark one. Okay. Also, if you need a refresher on skeletal muscle physiology, please do so. So I don't know if you remember this from Bio 32, you should, but an action potential arises at the motor neuron. That action potential, that positive 30 millivolts, is going to cause these calcium channels at the axon terminals to then release calcium into the axon terminal. And when the calcium gets released in here, that's going to cause these vesicles with the neurotransmitter, specifically acetylcholine, to then go towards the plasma membrane, fuse to the plasma membrane, and release that neurotransmitter by exocytosis. Okay, so again, action potential arise at the axon terminal. Calcium is then triggered to be released into that axon terminal. That calcium is going to trigger these vesicles to move towards the plasma membrane, to then release the neurotransmitter acetylcholine into the synaptic cleft. Okay, from then, the acetylcholine is going to bind to ligand-gated channels or chemically gated channels. You can call it either one, but ligand or chemically gated channels, the acetylcholine is going to bind to, and once it binds, it's going to allow sodium to start leaking in. to the muscle cell. And what that's going to do, that's going to take our negative membrane potential, negative 70 millivolts, okay, and it's going to increase that membrane potential, make it slightly more positive until it reaches threshold. Once it reaches threshold, then we can set an action potential, okay? And that's how that works. And we'll look over the diagram or the chart of the action potential here in a second. So if you don't remember these steps of the action potential arriving, calcium being triggered to be released into the axon terminal, the calcium triggering the release of the neurotransmitter in the vesicles out to the synaptic cleft, the neurotransmitter then binds to the ligand or chemically gated channels that allows for sodium to leak in until we reach threshold and then set an action potential. And then from then, if you remember, the action potential is going to go down to the T tubules. For the T tubules, that's going to trigger the release of calcium from the sarcoplasmic reticulum. And then from there, the calcium is going to bind to troponin, which is going to allow the actin and myosin to come together and do the cross-bridge cycling, which allows for contraction of the muscle until we need to relax. Okay, so if you don't remember all of those steps from Bio 32, you need to go back, review that information, and make sure you have that down. Because it does apply here as well. Okay, so this is that next part that I was just talking about. So once the action potential is sent after we've reached threshold, that action potential is going to travel down the T tubules. From there, that's going to trigger the release of calcium here from these calcium or these voltage-gated calcium channels. So the voltage-gated calcium channels are then going to be triggered to release that calcium from the sarcoplasmic reticulum into the cytoplasm. And from there, the calcium is going to bind to the troponin, which is going to move that complex of proteins out of the way so that actin and myosin can come together and create that cross bridge. And then from there, you're going to have cross bridge cycling occur, where it's going to attach, pivot, bringing these sarcomere closer together, and then deattaching. And remember, deattaching is going to require ATP. And then it'll reset, attach again, bring the sarcomere closer together, detach, reset. Cross bridge, bring the sarcomere closer together, deattach, reset, cross bridge again. It's going to do that over, over, and over, and over again until there's no more signal being sent to that muscle cell. And then once there's no more signal, the action potential is done, there's no more signal being sent, then that calcium is going to be actively transported back into the sarcoplasmic reticulum. These proteins, troponin and tropomyosin, are then going to block the active sites on actin again, and you're no longer going to be able to create that cross bridge. So again, if you do not remember all of these details, make sure you go back to your Bio 32 lecture notes so that you can review skeletal muscle physiology. Because again, those details are going to come back for this lecture. Okay. One thing that you should know, and I'm sorry, my allergies are really bad right now, but one thing that you should already know is that, again, once the action potential reaches the T tubules and the calcium is being released from the sarcoplasmic reticulum, that calcium binds to troponin here. Okay? In order to move the troponin and this other regulatory protein, the tropomyosin, out of the way and allow for the cross bridge to occur. Okay, so a really quick note about troponin, though. Again, it's the one that binds to calcium that allows for the cross bridge. The troponin, and specifically cardiac troponin, because we're talking about the heart here, but there is a special type of troponin for the heart called cardiac troponin. Cardiac troponin should remain inside cardiac muscle cells. Okay, so this troponin is found in the cytoplasm of the, or sarcoplasm, okay, is found in the cytoplasm of the cardiac muscle cells, okay? And so they should remain there. The only time you're going to see troponin outside of that cell is if the cell is damaged. I don't know if you remember this from tissues, but cardiac muscle tissue does not regenerate, okay? So once you have a heart attack and part of your heart dies, you do not get those cells back. They don't repair themselves. They do not come back. You are left without a functional part of your heart for the rest of your life, unless you get a transplant or something. So cardiac muscle cells have very little regenerative capacity. So you should only see that cardiac troponin inside the cells unless the cells have been damaged. So an increase in troponin I can spell, increase in troponin in the blood. I'm going to move this out of the way so that I have room. Increase in troponin in the blood indicates cardiac muscle damage. So we can use this. So we can do a cardiac troponin test, okay, to test for the levels of cardiac troponin in the blood to help differentiate between angina pectoris, which is just that pain in the chest from coronary ischemia or ischemia in general. So if there are, we're talking about the heart, so coronary ischemia, but ischemia, remember, is when you don't have adequate blood flow to a certain part of the body. So if we're saying coronary ischemia, you're not getting enough oxygen to the heart, okay, because the vessels have been narrowed, usually due to plaque. So if you have coronary ischemia, that can lead to angina pectoris, where you get a pain in your chest because your heart is starved for oxygen. Okay, so there's not enough oxygen getting to the heart, it's having to work harder, and you get a pain in your chest. However, at this point, no cells have died, okay, and they have not been damaged, so your cardiac troponin should still be in those cells. However, if you experience a myocardial infarction, okay, or heart attack, but remember, call it myocardial infarction. But if you experience a myocardial infarction, then those cells have died, have been damaged, and so you'll see troponin in the blood because those cells have burst open, all the troponin has been released, and it gets into the bloodstream. So doing a test on cardiac troponin to see the blood levels of cardiac troponin can give you the difference between whether a patient is experiencing angina, okay, so just like coronary ischemia, or if they're actually experiencing myocardial infarction. Okay, so that can help indicate the difference between the two. Okay, so that's pretty much it for the differences in anatomy between the cardiac muscle and skeletal muscle cells. We're going to have the next video, because I do these lecture videos in chunks, as you probably already noticed. The next video is going to be on the physiological differences between cardiac muscle and skeletal muscle.